Hello and welcome to the second part of our series on the somatosenses. Today we're going to be talking about pain and analgesia. This is of course part of our continuing series in physiological psychology. In our previous lecture we had talked about basic perceptual issues in the somatosensory realm, including somatosensation and receptors, including perception of details and objects, and somatosensation in the central nervous system. We're going to pick up from there and talk today primarily about pain and pain perception, and in particular pain relief through analgesia. And we'll finish up with a little discussion of itch, which is actually directly related to pain. But first we'll talk about how pain is multimodal. There is a sensory component of pain. That is the actual sensation of what kind of pain we're talking about, throbbing, or prickly, hot versus dull. So we've all experienced these different kinds of pains at some point. But there's also an affective component or an emotional component. Pain can be annoying, it can be frightening, particularly sudden, sharp, heavy pain. It can also be sickening. One of the things we know is that chronic pain is particularly debilitating because it just simply wears us down. We're in a constant state of stress, and so chronic pain is particularly difficult for people to deal with. And of course it depends on level, and everyone's a little bit different in terms of how much pain they can really tolerate versus where it becomes bothersome. So this is one of those areas that there is a lot of variance in terms of what people need, what's best for them, and it's of course an area of great difficulty because the primary drugs we have for treating pain are often drugs which have a pretty significant potential for addiction. So we'll start talking a little bit about the anatomy of pain. We talk about different kinds of pain. First is nociceptive pain. Nociceptive pain serves as a warning as to some sort of damage to the skin in particular. So when we talk about nociceptive pain, this is usually involving specific skin receptor types. So if you look at nociceptive pain, we're usually talking about free nerve endings, that primary kind of pain perception. Inflammatory pain is caused by damage to tissues, things like, if you look here, when we have some sort of damage to our knee, for example. Let's say we've injured your knee, that causes inflammation. That causes a different kind of pain. So nociceptive pain can include pain from cold, pain from pressure, pain from chemical burns, pain from heat. The chemical pain can also include chemical pain from something like hot peppers. So if you've made the mistake of cutting hot peppers and then touching something sensitive like your eye, you know that kind of chemical pain can be pretty excruciating. Inflammatory pain, again, is caused by damage to tissue. So if you cut yourself, that causes this kind of inflammatory pain. If you've got a problem in your internal environment, so let's say your appendix has gotten inflamed. And then finally, neuropathic pain can be caused by damage to the nervous system. So carpal tunnel syndrome is usually caused by the pinching of a nerve in your wrist, or if you have a spinal cord injury, or for example, if you might have a narrowing of your spine that pinches on a sensory nerve, that can cause neuropathic pain. And so these are all areas in which you can have different kinds of pain. There are, of course, cognitive and experiential aspects of pain. So pain isn't experienced in a vacuum that is on its own. Expectation can play a great role in knowing what to expect. This can help reduce pain. Of course, depending on how you phrase things, you can alter someone's pain perception. But helping them know this is going to hurt a little bit, you're going to feel some pressure, you're going to feel a sharp stick. You probably had these all happen. If you've ever had blood drawn or get your flu shot, just a sharp stick, because you want to know what to expect, and it'll actually reduce that perception of pain. Also, if you believe you've taken something to relieve your pain, you'll get some pain relief from that, and that's a placebo effect. Attention is another way in which your pain perception can change. If you shift your attention away from pain, that can reduce your pain. Emotional distraction. Positive distractions can result in reductions of pain. So distracting someone's attention from their pain and providing some sort of positive emotional distraction, getting them to laugh, will actually help reduce their pain. Finally, there are some individual differences in pain perception. So everyone's a little bit different in terms of what they can tolerate and how sharp pain might be. And this is one of the reasons why this is often a difficult area to study, because we don't really have objective measures of pain. We can see pain in things like elevated heart rate and blood pressure. People who are in pain will often show these kind of physiological responses, but again, those can be tied to other things. So it's very difficult to get direct measures of pain. So we can get pain relief through a variety of mechanisms. So we can use opioids. We can also use nonsteroidal anti-inflammatory drugs like aspirin, ibuprofen, naproxen, and acetaminophen. Acetaminophen, which is Tylenol, has very low anti-inflammatory properties, but does have some pain relief properties. It also has antipyretic properties, which is it reduces fever. But this is a good place to start if you're in pain. Certainly if you have inflammatory pain, you've hurt a knee, or if you've caused any kind of injury, these drugs are a good first line. Now you have to, of course, be cautious with drugs like ibuprofen, because they can cause thinning of the blood. So if you cut yourself, ibuprofen is not a particularly good choice at that point. But you also want to be careful if you're somebody who takes blood thinners. Those are certainly drugs to be very cautious with. And certainly talking with your physician is an important part of that. But you can start with these kinds of drugs to try to see if you can get some pain relief, particularly if we're talking about joint pain. Getting the inflammation down is oftentimes the most important part of getting pain relief. And so things like icing down joints, etc., these do result in reductions in pain. We're going to talk about opioids and how they relieve pain. Opioids are essentially a synthetic form of endorphins. They function the exact same way. They cause the same neural pathway, so we'll sort of talk about those together. Endorphins are, of course, released during things like high levels of stress, high levels of arousal through things like exercise. This is one of the reasons why athletes oftentimes don't realize how badly they've injured themselves, because they're in the height of competition. They have massive endorphin levels, so they keep playing despite the fact that they might have significant injury. Now, of course, the problem is they usually end up with a much worse injury because they don't know how much damage they've actually caused because of that. So it's something to keep in mind. And then finally, of course, we have placebo effects. Placebos, we know, can reduce pain. You can actually see in functional magnetic resonance imaging studies where providing a placebo actually changes someone's brain functioning in such a way that you can actually see that kind of pain relief. So in terms of relieving pain with analgesics, usually we talk about opioids as sort of being the main mechanism by which we can get the best kind of analgesia. So opioid mechanisms are systems that are sensitive to opioid drugs and similar chemicals. Opioid drugs are those that are derived from the opiate poppies. These opiates bind to receptors, which are called the mu receptors. These are found mostly in the spinal cord and the paraaqueductal gray area of the midbrain. So there are specific receptors that these bind to get that kind of analgesia. Endorphins are a group of chemicals that attach to the same brain receptors as morphine. Endorphins are what we call endogenous, that is, they are internally generated, whereas opiates are exogenous, that is, they are given from the outside and presented to the body's internal environment from the outside in through pills, injections, etc. So there are different types of endorphins for different types of pain. And so, but in general, we talk about this class as being related to endorphins and the best relief is usually got from opioids. But again, we have to be very cautious in using opioids to treat pain because there is such susceptibility to addiction. Now, one of the mysteries of pain is the ways in which pain are modulated. There's clearly a way in which pain can be blocked from the brain down. And this is what we call gate theory. This proposes that the spinal cord areas that receive messages from pain receptors also receive input from touch receptors and other axons descending from the brain. So we know, for example, that if you activate touch receptors in nearby areas to where an injury is, you can actually reduce the intensity of the pain from the actual injury. So sort of rubbing, touching somewhere near an injury can actually reduce the pain of a particular injury. So these other areas that provide input can close the gates by releasing endorphins and decreasing pain perception. And so it's one of the ways in which we can block out pain by using non-pain stimuli around an injury to modify the intensity of pain. And so this is still one of those areas where we don't exactly have the perfect idea of what's happening. But we do know from the brain down we can block the perception of pain. And again, this is done by endorphins, by adding opiates, or again by other ways in which you might get this kind of top-down pain relief. This is possibly the reason, or potentially an explanation, for why acupuncture and acupressure are able to relieve pain in some patients, because that stimuli causes this top-down closing of the gate for pain. So that's an important way on which we can think about alternative ways for treating pain. So if we take a look at the synapses for pain and its inhibition, substance P is the sort of neurotransmitter that causes pain. So we have pain neurons. So we have endorphins, that interact with substance P, and all of these can then be used to block pain. So ways of relieving pain through the para-aqueductal gray. So we have certain kinds of painful and other stimuli release endorphins, which inhibit an inhibitory cell and therefore excite the para-aqueductal gray. And so we can actually get excitation of the medulla and inhibition of areas coming up from the spinal cord. So placebos then are drugs or other procedures which have no pharmacological effect. They decrease the brain's emotional response to pain perception, but not the sensation itself. So it inhibits our perception of pain, but not the actual pain itself. Some alternatives to treating pain include cannabinoids, which are chemicals related to marijuana that block certain kinds of pain. We believe these act mainly in the periphery. That is, they don't block our pain perception, but actually block the sending of pain messages up the spinal cord. This is one of the reasons why cannabinoids are thought to be a potential treatment for peripheral neuropathy, which is pain without any sort of apparent cause. We'll talk a little bit about how peripheral neuropathy can develop. Capsaicin produces a temporary burning sensation, which is then followed by a longer period of decreasing pain. I'm not clear how, again, all of this works, but there appears to be some relationship with capsaicin and the potential way in which it decreases pain. So I want to talk a little bit about opioid analgesics, because again, this is an important current topic. So opioids are substances that interact with the mu receptor. So while they don't all come from poppies, we call them all opioids anyway. So we have different kinds of opioid drugs that interact with opioid receptors. So an opioid analgesic will be, in general, some kind of opioid agonist. This is any substance that has an affinity for the mu receptor and exerts the same effects as morphine. And again, we use this sort of morphine as the comparison because it's sort of the purest of the opioid analgesics. So these include drugs like morphine, heroin, Dilaudid, Demerol, fentanyl, oxycodone, codeine, hydrocodone. These are all examples of pure opioid agonists. These are, of course, drugs with high potential for abuse. In particular, I selected these. There are additional pure agonists, but these are the ones that you will hear the most about and have really the highest potential for abuse. These, of course, also have the sort of highest ability to relieve pain. These are pretty powerful pain relievers. Partial agonists are drugs that have an affinity but only partial efficacy. That is, they will bind to the mu receptor, but they don't provide the same kind of analgesic action. The primary one of these is buprenorphine, which is also known as Buprenex, which is included in a drug called Suboxone. Suboxone is a drug that is currently being used to treat opioid addiction. Suboxone is a pretty remarkable advancement in this treatment area. Suboxone includes buprenorphine, which activates the mu receptor, and as a result limits the kind of withdrawal from a drug like heroin. And so you don't get the withdrawal that you might get for somebody who just goes cold turkey. Suboxone also includes naloxone, which is a pure antagonist we're going to talk about in a moment. But what essentially the naloxone does is it makes it such that if a person who's taking Suboxone ingests heroin, morphine, oxycodone, any of the drugs that we've talked about, they will get absolutely no effect from that drug. And as a result, people don't relapse when they're on Suboxone because they don't get any of the high, they don't get any action from that dose of heroin or dose of oxycodone because of the naloxone component, but the buprenorphine has kept them from going into withdrawal. There are mixed agonist-antagonist drugs. These bind to opioid receptors, particularly what we call the kappa receptor. It causes analgesia in non-opioid dependent persons, but may precipitate withdrawal in opioid dependent persons. So these are drugs that might be useful as first-line analgesia in patients who are not opioid dependent. And then finally we have pure antagonists, and these have an affinity for the mu receptor but are devoid of any morphine action. And these are drugs like naloxone or Narcan and naltrexone, which has several different brand names. Naloxone or Narcan is a very important drug because this can immediately reverse the effects of an overdose of any of the opioid drugs, because what it does is it blocks the mu receptor but causes no action at that receptor. As a result, any heroin in the system, any oxycodone in the system will not initiate a response at the mu receptor, and as a result, you end up with a reversal of an overdose. Now, the problem is the person then needs to be taken to a hospital very quickly because they're going to go into withdrawal very quickly. But this is a life-saving drug, and it's available in some jurisdictions without a prescription. So here's a look at many of the opioid analgesics and if they're synthetic, semi-synthetic, and how they affect the opioids. So morphine is the natural high chemical class of opiates, as is codeine. It's also a natural drug. These are full mu agonists. Then we have the oxycodones, hydrocodones, hydromorphone, oxymorphone, fentanyl, Demerol. Then we get down into the mixed partial agonists, which include things like tramadol, which is a semi-synthetic mu agonist. And then we, of course, get the complete antagonists, sorry, is what I should say, of the mu receptors. So the major pharmacological effects of opiates are analgesia, which is pain relief, euphoria, which is the high people feel from these drugs. The biggest danger of these drugs is their depression of respiration. In fact, people that overdose stop breathing, and that's why they tend to die. And that's because of the high number of mu receptors down in the brainstem, in particular in the medulla oblongata. You also get suppression of cough, which is why some cough medications will include codeine. So there are codeine cough syrups. This is famously what Lil Wayne overdosed on, was a codeine cough syrup. They also are sedating and can relieve anxiety. They can, however, cause nausea and vomiting, particularly in people who have taken too much. We'll talk here in a minute about the pharmacogenetics of hydrocodone and why some people will become very nauseous from taking these drugs. You also get gastrointestinal symptoms. Oftentimes these drugs can cause pretty severe constipation, and in fact this can be a severe side effect of these drugs, and will often result in needing treatment for that itself. These drugs also cause pupillary constriction and have some endocrine side effects. So as I was mentioning a moment ago, one of the areas in which we're starting to learn more about how these drugs affect people has to do with the metabolism of hydrocodone. So hydrocodone is metabolized by the cytochrome P2DG enzyme into hydromorphone, which is a more potent mu agonist than is hydrocodone. There are genetic variations in the expression of cytochrome P2DG, which influence the relative amount of analgesia and side effects from hydrocodone. That is, there are 4 different genotypes that we know about. So, for example, people who are highly efficient metabolizers will have a great deal of cytochrome P2D that will turn a lot of hydrocodone into hydromorphone. And so these are the people that oftentimes will get nauseous from the metabolizing of hydrocodone. Then we also have people who are poor metabolizers who get very little analgesia from hydrocodone because they don't turn enough into hydromorphone, and then there are sort of 2 in between. So there is a future in which we might be looking at genetic profiling to determine which drugs we might want to give somebody. So the last couple of areas to talk about have to do with sensitization of pain. We'll talk about gender differences in pain, and then finally itch. One of the mechanisms that we need to talk about is the body increases its sensitivity to pain. So damaged or inflamed tissue releases histamine, nerve growth factor, and other chemicals that increase the response of nearby pain receptors. So all of this is part of trying to heal from the injury, but results in alteration of pain receptors. So some of those receptors become potentiated after an intense barrage of painful stimuli, and this leads to increased sensitivity, or what can be chronic pain. So chronic pain can result from an injury in which the pain receptors have become overly sensitive. And so when you hear people who have severe peripheral neuropathy talk about it, they talk about how their clothes are painful to wear, that any touch is excruciating. And that's because these pain receptors have become hypersensitive. And so this is a really important area where we need to try to figure out the best way to figure out how to treat those patients and how to prevent this kind of chronic pain. Now, there are some gender differences in pain perception. Women are more likely to see treatment for pain and have greater diagnosis of chronic pain. And this doesn't mean they perceive pain necessarily different. There are, of course, societal differences in how people are supposed to be tough or not tough. So some of this may be socialized. Not all of this may be biological. But in some experimental studies, women have been shown to have lower pain thresholds. But again, we get into these issues of societal expectations. We do know that pain thresholds can be influenced by endogenous hormones. Pain sensitivity decreases late in pregnancy. This makes perfect sense. If you're going to design a biological system in which people have more than one child, you're probably going to want to limit the pain of childbirth, and so pain sensitivity goes down late in pregnancy. Pain sensitivity also varies across the menstrual cycle, with higher pain tolerance during the follicular phase. This is during ovulation, or about the point of ovulation. Again, higher pain perception might be necessary for that kind of reproductive activity. We also believe that men may have a larger response to endogenous endorphins. That is, men might get more pain relief from their own internal endorphins. We're still trying to figure some of this out, but this is a preliminary part of trying to understand things like sex differences in susceptibility to opioid addiction. So one of the largest classes of people that are involved with getting addicted to opioids are women, particularly middle-aged and older women. And so some of this may have to do with alterations in pain perception. So the final topic here is itch. The release of histamines by the skin produce itching sensation. This activates a distinct pathway in the spinal cord to the brain. These impulses travel slowly along this pathway. One of the things that's really interesting about this is pain and itch have an inhibitory relationship. Opiates actually increase itch, while antihistamines decrease itch. And so while you decrease pain, you can increase itching. And this is also perhaps related to why injuries itch after they're healing, because the pain has gone away and now the itch has taken over. All right, well, that's our introduction to pain and analgesia. Thank you for tuning in.